Hello and good evening, everyone. Hello and good evening, everyone. Welcome to the ISPAE ACES meeting. This is the 25th meeting, and this is the first time we are meeting this year in 2023 with the new team. And this year, it will be 3 monthly. So we welcome you all to the first ISPAE ACES meeting on Pheochromocytoma and Paraganglioma. May I now please invite Dr. Ahila, our president of ISPAE, to proceed further. Over to you, ma'am.
Thank you so much, Zara. Good evening, everyone. It's lovely to see all of you here, and it's a wonderful start to 2023 with ISPAE ACES meeting. I am deeply thankful to all of you for taking time off to participate in this program. And my deep thanks to Dr. Christina Pomparaki, who's taken so much time off and has agreed to give a lecture to us on Pheochromocytoma and Paraganglioma. And I'm also deeply thankful to Dr. Vijay Sarathi, Professor Vandana Jain, and Dr. Anurag Bajpai for helping us and make this program a successful event. And we are looking forward to a wonderful academic session. Thank you so much, and welcome Dr. Christina once again. And we hope to see you again sometime directly in India too at some point. Welcome. Thank you.
Would be great. Thank you.
And I now welcome Professor Vandana Jain, who is the Professor of Pediatric and Pediatric Endocrinology at the All India Institute of Medical Sciences at New Delhi. She has deep clinical interest on effect of infancy growth and fat gain trajectory on later cardiometabolic outcomes. She is also interested in research in metabolic syndrome and non-alcoholic fatty liver disease in adolescents. And she is looking at improving and outcomes in children by innovations in diabetes care. And she has an inbuilt and a long-drawn interest in disorders of sex development in Indian children. Thank you so much, Professor Vandana Jain, for agreeing to take this session forward. Thank you and welcome.
Yeah. Very good evening to all the participants, and thank you, Dr. Ahila, for that introduction. And I'm speaking from Sarnath, Varanasi today. So I hope my audio is clear. And it's really good to participate in this space. Is 25th edition. I mean, really, it has gone leaps and bounds. This program is very useful for all of us as a continuing platform for enriching our, knowledge and skills in pediatric endocrinology. So for today, Dr. Meghna, who is a fellow with Dr. Raghupati at IGICH Bangalore, she will be presenting the first case on pheochromocytoma, and then we will have some discussion around it. So now I welcome Dr. Meghna to begin with her presentation.
Are my slides visible, ma'am?
Yes, they are visible. Make them full screen, please. Yes.
It's full screen now.
Yes.
Good evening, everyone. I'm Dr. Meghna N, a clinical fellow in Department of Pediatric and Adolescent Endocrinology at IGICH Bangalore. I'm presenting this case under the guidance of Dr. Raghupati P and Dr. Vani H.N. And for today's case presentation, Dr. Vandana Jain Madam is the moderator. An 8-year-old boy hailing from Harihara Taluk, Davangere district, Karnataka, to us the chief
No, you're not audible.
of excessive sweating, headache, pain, abdomen, and vomiting. He was first born to a
Meghna, can you hear us?
Meghna?
Who presented to us with complaints of excessive sweating for the past 3 months.
So, Dr. Vandana, I think her audio is very weak. Maybe until she stabilizes her internet, maybe we can request Dr. Christina to proceed, or maybe the Harish
I
case
think
with
so.
Anurag sir. Something
Yeah,
can be
I think
planned.
so. I'll in the meanwhile, I'll call
Zalak?
and I'll call her and tell her to take care of her audio. Okay.
Professor Vandana, can you just invite Dr. Christina so that she can deliver her lecture?
Okay, we begin with Dr. Christina's talk. Okay, okay.
Yeah.
So sorry for that glitch with Meghna's audio. So we would first now request Dr. Christina Pamporaki to deliver her talk. So I'm happy to introduce her. Dr. Christina is Senior Endocrinologist, Head of Clinical Research, Adrenal Unit at Medical Clinic 3, University Hospital, Carl Gustav Karras, Preston. She is MD PhD and she has many achievements to her name. She has been the young investigator and she won an award for it in the International Symposium on Pheochromocytoma at Kyoto, Japan. She has also received a habilitation scholarship from the Medical School of TU Dresden. She is a PI of International Multicenter Clinical Studies on Pheochromocytoma and Paraganglioma, and has participated in the international guidelines for this. And she has been speaker at various international forums for Pheo and Paraganglioma. So, Dr. Christina, we are looking forward to hearing from you.
Thank you very much.
Conditions. Yeah.
Thank you very much for the kind invitation. And I hope you can see my screen.
Yes, we can. Thank you.
Great. So I am a senior endocrinologist. So I'm very happy that I have an audience of pediatricians today. And thank you for the opportunity to discuss with you today updates on diagnosis of pediatric patients with pheochromocytoma and paraganglioma. As you all know, pheochromocytomas and paragangliomas in children are quite rare, with an annual incidence of 1 case per 2 million per year. Although rare, they are quite lethal, so correct and early diagnosis is of paramount importance to improve patient outcomes. We have to appreciate that pheochromocytomas and paragangliomas are very slow-growing tumors. It needs 6 to 9 years for 1 centimeter tumor to reach 2 centimeters, and another 6 to 9 years to reach 3 centimeters. If we take into account that the average diameter at diagnosis is 3 to 4 years, you can appreciate and you can understand that many of the young adult patients that we see as senior endocrinologists in our outpatient clinics are rather pediatric patients, as the tumor has started its development during childhood. Therefore, we can expect that the prevalence of pediatric PPGL may be higher than the one reported nowadays. Clinical presentation of these tumors in children is dominated by the manifestations of the catecholamine excess, the catecholamines that are secreted from the tumor. Signs and symptoms may be paroxysmal, may occur unexpectedly, or even after a trigger of a particular stimulus. Children may present with paroxysmal hypertension. However, if you do not detect hypertension during the clinical evaluation, it is of paramount importance that we do not discount the catecholamine-producing tumor in children that nevertheless present with other signs and symptoms of catecholamine excess, such as palpitations, headaches, sweating. There have been symptoms like visual disturbances or decline in school performance, weight loss, or polyuria that have been described, and they should warrant our attention. Importantly, nowadays, some children are being diagnosed due to incidental adrenal masses that are detected in imaging studies that have been performed for unrelated reasons, the so-known incidentalomas. And more commonly, children are now diagnosed during surveillance programs due to pathogenic variants in known susceptibility genes. In these latest 2 conditions, it may be that the children are diagnosed with tumors at an early stage of development, which means that the children may be completely asymptomatic. So we have to be careful. Over the last 20 years, we have identified many genes that cause pheochromocytoma and paraganglioma, and the prevalence of the hereditary disease in children has increased from 40% that we once thought to even 80% nowadays, a prevalence that it is twofold higher than the one reported in adults. So the home take message is that pediatric PPGL has mostly to do with hereditary disease. If we want to categorize our susceptibility genes in two main categories, we could say that we have the cluster 1 tumors, where these tumors are due to pseudohypoxia signaling pathways. And in this category, we can include tumors with pathogenic variants in the von Hippel-Lindau syndrome, or in the subunit of the succinate dehydrogenase complex, or the fumarate hydratase. And then the second group is with cluster 2 tumors due to activation of kinase receptor signaling pathways. And in this category, we can include pathogenic variants in the red pronto-oncogene, or in the neurofibromatosis gene, or in the TMEM127, or in the MYC-associated factor, the so-known MAX. Of course, there is a third category, a third cluster, which is mainly due to somatic mutations, but briefly, these are the two main categories where we group our susceptibility genes. We have previously shown in studies that among pediatric patients, the most common pathogenic variants are due to pseudohypoxic genes, and in particular due to VHL and SDHB, whereas pathogenic variants due to cluster 2 tumors are not often, are very rare in children. So if we have a child, we expect that this child probably will have a cluster 1 tumor if a genetic testing is positive. So once we suspect a PPGL, a pheochromocytoma, paraganglioma in a child, we have to choose for an appropriate test. So according to our Endocrine Society guidelines, the appropriate biochemical test to screen for pheochromocytoma is metanephrines, the all-methylated metabolites of catecholamines. We can measure metanephrines as free metanephrines in plasma, or we can have urinary metanephrines, either free or more commonly fractionated. Of course, these guidelines were based mostly on studies that have been focused on adult cohorts. However, we still have few reports that have been focused on pediatric patients, and at least 2 very good studies that show that metanephrines in plasma and in urine are an excellent test to diagnose a pheochromocytoma in children. So So at this stage, I would like to draw your attention in a third biomarker, which is the so-known methoxytyramine. Methoxytyramine is the O-methylated metabolite of dopamine, and it is quite a useful marker for the pediatric patients. Methoxytyramine is not only very helpful to identify dopamine-producing tumors, which although rare, are more common in the pediatric patients. But methoxytyramine is also important because if we add it in the panel of metanephrines, we can improve the test's diagnostic performance. Importantly, methoxytyramine has been established to be a very good predictor of metastatic disease. As you can see in this figure, if we have extremely high levels of methoxytyramine, it is almost sure that the child has metastatic potential. However, we should keep in mind that methoxytyramine is only useful to measure in plasma. Urinary methoxytyramine is useless. Urinary methoxytyramine reflects the clearance and the metabolisms of L-DOPA and has nothing to do with dopamine-producing tumors. So methoxytyramine is useful if we use blood samples and if we measure metanephrines in blood. So the first aspect we have already clarified. to screen for PPGLs, the best metabolite are metanephrines. But it is important to have a reliable method, a reliable assay. And the gold standard method to measure metanephrines are spectrometric methods. We should never measure metanephrines with immunoassays. Previous reports have shown even a quarter of false negative results with immunoassays, which means that we may lose cases with tumors, especially if they are small. So only with spectrometric methods. Apart from the appropriate metabolite and the appropriate method, it is important to implement pre-analytical precautions to further minimize false positive results. During biochemical workup, we should assure that the child has minimal psychological and emotional stress, that the child has no hypertensive crisis, is not acute severely ill, or is not under severe stress. If we measure metanephrines in blood, it is important that we measure blood using an intravenous cannula that should be located 20 minutes before, and during this 20 minutes time, the child should be in supine position. So one would say, oh, why this great, so interesting, so many precautions just to measure metanephrines? Why is it so important that we do not have stress? In order to convince you of how sympathetic activation can influence our results, I will try to remind you the catecholamine metabolism. As you can see here in the bloodstream, metanephrine is mostly derived from the metabolism of epinephrine in the chromaffin cells. However, normetanephrine, which is also the most important metabolite for diagnosis of PPGLs, is by 75% derived from the sympathoadrenal release of norepinephrine, and only 23 to 25% comes from the metabolism of norepinephrine in the adrenal medullary cells, which means that if here we have a sympathoadrenal activation from a stress situation, it is quite common that we get small elevations in normetanephrine. So we have to be very, very careful. Of course, I realized that you have a young child in supine position for 20 minutes, or to use an intravenous cannula in children that usually have needle phobia. It's quite demanding and challenging. So if we cannot follow the appropriate precautions, it's better not to draw blood. It's better to use urine samples. Historically, we can use 24-hour collections of urine to measure metanephrines, but sometimes urine collections are also challenging among children. So nowadays, more and more we use this spot morning urine. Irrelevant of the type of the sampling, we have always to keep in mind that the laboratories should provide us with appropriate reference intervals, as the metabolites present with differences according to age and sex. In particular, to show you how important it is that our laboratories have appropriate reference intervals for children and never use reference intervals for adults, you can see here that methoxytyramine and normetanephrine are very high in neonates and drop dramatically and rapidly during the first year of age to level off later on, whereas metanephrine increases during early infancy and remains higher in younger children than older adults. The same is also within 24-hour urinary collections, where the urinary output can be even 4 times higher in the adulthood or in the early teenager compared to younger children. And we also know that urinary outputs are higher in males than females. So you can understand that these differences are very important. If we go for spot urine, the situation becomes even more trivial. As spot urine samples, the metabolites are corrected for creatinine. And you know better than me that in children, creatinine is associated and influenced by BMI, exercise, diet, or even more important, on muscle mass. So due to these dynamic changes in urinary excretion of creatinine and metanephrines, it is very clear that we need reference intervals adjusted for age. So once we have done our biochemical test, it is important to know what we expect to see in a pediatric patient with PPGL. Most children with PPGL harbor noradrenergic tumors, which means that we expect elevations in plasma or urinary norepinephrine, but we expect to have low levels in metanephrine. As you can see in this middle figure, pediatric patients with PPGL show significantly lower levels of metanephrine than adult patients with PPGL. These findings are not as surprising if we think and we appreciate that most of the children, harbor pathogenic variants due in pseudohypoxic genes, which, as we all know, lack epinephrine production, these tumors, because these tumors cannot express PNMT, an enzyme which converts norepinephrine to epinephrine. With other words, noradrenergic tumors can, due to pseudohypoxia signaling pathways, produce normetanephrine, but not metanephrine. Apart from the fact that pediatric patients with PPGL are expected to have higher prevalence of hereditary disease and higher prevalence of noradrenergic tumors, we have to appreciate that pediatric patients present more often with multifocal tumors compared to adults, and more often with extraadrenal tumors compared to adults. So pediatric patients with PPGL have specific clinical and biochemical characteristics that distinguish them from the adult population. So once we have positive biochemical test results with elevations of at least one metabolite higher than the twofold of the above reference interval, then you, as pediatricians, you are justified to proceed in an imaging study. The decision of what kind of image we are going to use should take into consideration, of course, the radiation. In our department, we proceed with MRI, but I have to be honest with you that many colleagues in other centers may also use occasionally CTs if they want to have a very good imaging at least once. With the MRI, we also have another problem sometimes with very young children because they are not compliant. And then comes the question if we have to use sedation. So it's quite trivial. However, at least in our center, we prefer doing an MRI. The decision of proceeding to functional image should also be based on several considerations. In our department, we proceed to functional imaging when we do not have a clear identification of the tumor in the conventional imaging, or the patient has metastatic disease, or if the patient is at high risk for metastatic disease. For instance, if we have a pediatric patient with an extraadrenal large tumor, high methoxytyramine levels, or SDHB pathogenic variants, then we will perform functional imaging before operation. In all other cases, we will do functional imaging after operation, and if biochemical testing is positive, which means that we have indication of residual disease. With the question what type of functional imaging, as we all know, if we have a child with a known pathogenic variant in a susceptibility gene, we can use, according to the pathogenic variant, the appropriate functional imaging. In case we do not know the genetic status, we usually ask for a gallium dotatate that has superior diagnostic performance, especially among children with high metastatic potential or those with SDHB pathogenic variants. So once the child is diagnosed and is operated, we are called after operation to plan an appropriate follow-up. According to the endocrine guidelines of the adults, we should follow up patients with PPGL And we should follow up patients with hereditary disease lifelong, where those with negative genetic testing for at least 10 years. However, there have been many questions raised if for the pediatric patients, the 10 years is enough. If we also take into account that the prevalence of metastatic disease is much higher in children, and that metastatic disease is usually diagnosed years after the initial tumor diagnosis, we are not very comfortable with this 10 years follow-up. Indeed, we have recently shown in our group that among patients with sporadic PPGL, so patients with negative genetic testing, we have a 14% rate of false positive results. And so, excuse me, a 40% rate of recurrence disease, and mostly due to metastatic disease. So it seems that even patients with negative genetic testing, they're at high risk of recurrent disease. Importantly, we have shown that at least 70% of those that will develop recurrent disease, they were diagnosed at least 15 years after initial tumor diagnosis. So if we have stopped follow-up in 10 years, we would have missed more than 20% of other patients that would develop recurrent disease. In this cohort and in this study, we have also included 50 pediatric patients that have shown similar results. So these findings not only highlight the need for long-term follow-up, even in cases of negative genetic testing, for at least 15 to 20 years, but they also highlight the need for proper transition to the adult care. No patient with PPGL, pediatric patient with PPGL, should be lost to follow-up. It is very important that we have very good connection and very good transition strategies in our hospital. And with this slide, I would like to close and thank you for your attention.
Yeah, thank you. Thank you, Dr. Christina, for that wonderful lecture. And we can take a few queries. And what I can see in the chat box, there's one question from Dr. Zalak, that what are the age-wise cutoffs for the plasma and urinary meta and non-metanephrine? And what is the age-wise distribution of pheochromocytoma and paraganglioma? Would you like to take that question up, please?
Yes. The age cutoffs, we calculate them. There is a publication that I can send you from our group from 2020, where we have tables for each metabolite, normetanephrine, metanephrine, and methoxytyramine, with appropriate upper cutoffs for each specific age every 5 to 6 years, because it's not like we have 2 or 3, we have for specific age groups. So I can provide you also for urine. There is also for spot urine, for 24-hour urine, and for plasma. So they're all online available, and you can have them in the outpatient clinic. So the age-wise distribution of the PCS. So most of the children have paragangliomas. The pheochromocytomas are quite rare, at least in our study. I cannot tell you exactly what percentages are they, but I would say more than 60% are PPGLs and only 30 to 40 Pheos, if very globally. Follow-up plan. So as I said, the most important thing to remember as pediatricians is that you should follow lifelong these children. So there are specific also guidelines for according to specific mutation of what we should measure. And I suppose I may have it also here in the yeah. So I don't know if this table is useful, but as you can see, we have specific plan according to mutation of what we measure in every visit, and if we need also imaging studies. So as you can see, we have for STHB every at least once a year, metanephrines. It's also important to measure methoxytyramine in these patients. So blood, we prefer blood to urine. And also there is imaging studies every 2 years to 3 years. then we start from the age of 6. So we have specific standard operating procedures for each mutation, age to start the surveillance if the patient has known pathogenic variant, or if the patient has already been operated for the tumor, it's the follow-up. And as you can see, we measure biochemically and clinically every year at least. And in some cases, like the STH, we also have imaging studies every 2 to 3 years. So yes, there is specific follow-up plan according to the mutations, pathogenic variant status. The youngest child, I think the youngest child was 4 years old with the VHL, and I don't think I have never seen in my life, or I do not expect to see a pheochromocytoma in a child younger than 4 years old or 3 years old. So this is also important for you as pediatricians, because if you see a very, very young child with a tumor in the adrenal and you suspect neuroblastoma, so if it is very, very young, so 2 years old, it's almost impossible to be a pheo. On the other hand, I would like to take up the opportunity of this question, and I would like to draw your attention. Whenever you see a child with possible neuroblastoma, please always exclude the pheochromocytoma, although rare, before you biopsy. Because if you do a biopsy and it is a pheo, it is very dangerous for the child. You know that we do never do a biopsy in a pheochromocytoma. So always keep in your mind, it's a rare tumor. If you see something that looks like neuroblastoma, just officially exclude a pheo before you proceed to a biopsy. So if you have a very, very young child, younger than 4 years old, it's almost impossible that you can see a pheo. I don't think there is a report, and someone can correct me if I miss something, but yeah, this is what I believe.
Okay, there are a few more questions, Dr. Christina. One is that if VHL mutation has been diagnosed in both child and father, which thyroid carcinoma is common? Is both follicular and papillary carcinoma possible in this scenario?
You're talking about STH? Have I heard you correct?
The question was on VHL. I don't know. VHL may typically you won't have thyroid carcinoma, would you? I'm not sure. The question was VHL.
For the VHL, I'm not sure. We expect to see bilateral tumors, multifocal tumors, large tumors, and about the thyroid carcinoma, I'm not very familiar of that, what kind of carcinoma you can see, because it's the pediatricians that take care of this kind of things. I only know about the men, and of course with men's syndrome, we don't see children.
Hemangiomas, renal cysts, and carcinomas. So I think thyroid would be very rare. I don't think thyroid.
Yeah.
I'm not sure about that. Okay.
Yes, it would be very rare.
I also had one question that typically metastatic pheo or metastatic paraganglioma rather would be seen only with HT or rarely have this in VHL mutations as well. Metastasis.
No, we can see metastasis in VHL. It's not so rare, but why you don't see sometimes metastatic disease in your children is because, as I said, metastasis can even be diagnosed 18 years later when the patient is already an adult. So this is how the transition is important. So metastatic disease can be seen and also in VHLs. Of course, not so often as with the SDH, but it is there. We should be aware of that. As I said, and metastatic disease is quite often in children also with negative genetic testing. If you have, though, a child with cluster 2 tumors, although it's very rare to happen, then indeed metastatic disease is not the case. So it's extremely rare for the cluster 2 tumors. But in cluster 1 tumors, no, we should always be alert. Metastatic disease is always a possibility, unfortunately.
Okay, Dr. Christina, thanks a lot. I think I would request you to stay on for the presentation by Dr. Meghna. She will be presenting a case on PO and.
Great, thank you.
Dr. Meghna, are you ready now? Yeah, thank you.
Yes, ma'am. Can you hear me?
Yes, you're audible.
Hello. Okay, okay,
You're
ma'am.
audible.
Meghna, will you share screen or do you want me to share?
I'll share the screen, ma'am.
Meghna, can you
Is
say
my
a few
screen
words?
visible now?
Yeah.
Yes. Yes.
Yes, ma'am. Can you hear me now?
Yes, but intermittently your voice
Is
is breaking.
my
I'm just keeping my
screen
fingers
visible
crossed.
now?
Your screen is visible, but now we can't see the presentation.
Meghna, can you ask Zalak to help you with the presentation, and can you just speak? Because when you open the video, your voice is actually becoming
Now, ma'am, is the
tremulous.
presentation visible?
But your voice is not good.
Visible, but your voice is again not coming very smoothly.
Okay.
Meghna.
Okay, ma'am.
Let's
Okay.
see.
So I will exit.
I'll
What
do the
about?
screen sharing, Meghna.
I have stopped screen sharing.
I'll do the screen
I've stopped screen sharing, ma'am.
Maybe Zalak, you can try sharing the screen, and maybe Meghna can speak without the video. Maybe it is better.
Can you see the screen now?
Yes, we can. And it
Yes,
is
make it full
yes.
screen. Yes.
Meghna, you can start now.
Okay, ma'am. I'm starting now.
Next slide.
Good evening, everyone. Next slide, please. So this 8-year-old boy hailing from Harihara Taluk, Davangere district, Karnataka, presented to us with the following chief complaints. He presented to us with excessive sweating, headache, pain abdomen, and vomiting. He was first born to a non-consanguineous parents who presented to us with complaints of excessive sweating for the past 3 months, headache for 2 days, which was dull aching type more in the occipital region with no aggravating or relieving factors. Pain abdomen for 2 days, generalized dull aching pain, non-radiating, associated with vomiting, but without any aggravating or relieving factors. And vomiting one episode, which was non-projectile, non-bilious, or blood tinged. Next slide, please. No seizures, blurring of vision, or loss of consciousness, no history of swelling in the neck, tremors, or protrusion of eyes, no history of periorbital puffiness, decreased urine output, or history of passing cola-colored urine. He had no history of abdominal mass, recent history of weight gain or weight loss, or history of drug intake. Next slide, please. Patient had no history of similar complaints in the past or previous hospitalization. He was first born to non-consanguineous parents with no history of similar complaints in any other family member or any thyroid disorder in the family. He was a term baby, vaginal delivery with a birth weight of 3 kgs, developmentally appropriate for age, studying in 3rd standard with good scholastic performance. He was immunized up to date as per national schedule. So coming to the summary at the end of history, we had an 8-year-old boy, first born to non-consanguineous parents, with no significant past history or family history, with normal development, who presented to us with complaints of excessive sweating of 3 months duration and headache, vomiting, pain abdomen of 2 days duration. So at the end of history, our differential diagnosis were hyperthyroidism, hypertension secondary to renal or endocrine cause, an adrenal tumor, or raised intracranial pressure, migraine. On examination, patient had a heart rate of 136 beats per minute, which tachycardia was present. BP was 126 by 92 millimeter mercury. BP measured in all 4 limbs were above 95th centile plus 12 millimeter mercury. Femoral pulses were well fed. Coming to anthropometry, his weight, height, and BMI were within 25th to 50th centile, as I've shown in the IAP charts in the next slide. Next slide, please. Next slide. On examination, on general examination, diaphoresis was present. On fundus examination, bilateral papilledema was present. He had no neurocutaneous markers, no evidence of goiter. His SMR was normal for his age. Next slide. On systemic examination, on parabdomen examination, it was soft, non-tender, no organomegaly was present. Central nervous system examination, child was conscious, oriented with no focal neurological deficits. On cardiovascular system examination, S1, S2 were heard, no murmurs. Respiratory system, bilateral air entry was equal with normal vesicular breath sounds heard. Coming to the summary at the end of history and examination, we had an 8-year-old boy, firstborn to non-consanguineous parents with no significant past or family history, with normal developmental milestones, who presented to us with complaints of excessive sweating of 3 months duration and headache, vomiting, and pain abdomen of 2 days duration. On examination, the child was found to have tachycardia, diaphoresis, hypertension, and bilateral papilledema. So the differential diagnosis at the end of history and examination came down to hypertension secondary to probably an endocrine cause with secondary to catecholamine excess or mineralocorticoid or glucocorticoid excess, or secondary to a renal cause. So we started to work up for the cause of hypertension. Secondary causes of hypertension are more common in younger children, with 80% of causes attributable to renal parenchymal or renovascular causes, and 11% attributable to endocrine causes, and 2% to cardiac causes. Next slide, please. So initial investigations revealed normal renal function, with venous blood gas was normal, serum electrolytes were normal, urine routine microscopy were normal. His thyroid function tests were also within normal range. Next slide, please. So we went ahead with imaging. USG abdomen and pelvis was done with renal Doppler, which showed a well-defined isoechoic lesion with cystic and necrotic areas within, with mild increased internal vascularity in the right adrenal gland and a similar lesion in the left adrenal gland. Renal artery Doppler was normal. So we went ahead with a contrast-enhanced CT of the abdomen, which showed a well-defined heterogeneously enhancing soft tissue density mass lesion in the right adrenal gland with ill-defined hypodense non-enhancing areas of necrosis and cystic changes within. So in the image to your right, I've marked in red the right adrenal cortex, and the area within it is the mass in the adrenal medulla. CT attenuation on a non-contrast image was found to be 40 Hounsfield units. Number less than 10 Hounsfield units is suggestive of adrenal adenoma, and a number more than 20 Hounsfield units is suggestive of a pheochromocytoma. The absolute and delayed washout were 95% and 67.9%. Next slide, please.
I take liberty to intervene, Meghna, and please go back to previous slide, Zalak. So the highlighted part may not represent the cortex. So indeed, it is just a part of the tumor with more of a pseudo-encapsulated periphery. So it does not mistake it as a cortex.
Oh, okay, sir. Okay, thank you. Next slide, please. A similar mass lesion was noted in the left adrenal gland, but both lesions were well defined and did not show any local infiltration. All these features were favoring bilateral pheochromocytoma. So we went ahead with a 24-hour urinary norepinephrine and metanephrine levels. Urinary norepinephrine levels were elevated more than 4 times the upper limit of normal range, whereas the metanephrine levels were not elevated. We confirmed the adequacy of sample collection by measuring a 24-hour urinary creatinine as well. 2D echo showed structurally normal heart with normal biventricular function, with turbulent flow in the IVC due to mass lesion compressing the IVC. MRI brain and CT thorax were normal. Next slide, please. Since it was a case of bilateral pheochromocytoma, we did a Dotanok PET CT scan, which showed a large, well-defined, heterogeneously enhancing soft tissue mass lesion with areas of internal hypodensity and increased tracer uptake. Similar lesion was seen in the left adrenal gland with no significant enlarged abdominal or retroperitoneal lymphadenopathy. There were no tracer avid skeletal or visceral lesions. Next slide, please. I've marked the lesion in red arrows in the next slide on both the right and left side. Next slide, please. Yes. Coming to medical and surgical management, pre-operative management of hypertension was, next slide, please. Next slide. Preoperatively, we managed hypertension. On day 1, the child was started with taprazosin, which is a selective alpha-1 antagonist. It was started at a dose of 0.1 milligram per kg per day, divided into 4 doses, and gradually increased up to 0.4 mg per kg per day. With prazosin, his blood pressure, which was above 95th plus 12 millimeter mercury, came down to lie between 90th and 95th centile, but tachycardia was still present. So we added atenolol, which is a cardioselective beta blocker, started at a dose of 0.5 mg per kg per day, divided into 2 doses, and gradually increased it up to 1 milligram per kg per day. With this, the heart rate came down from 124 to 100 beats per minute. Since the BP was still lying between 90th to 95th centile, we added tab amlodipine, which was started at 0.1 mg per kg per day and gradually increased up to 0.4 mg per kg per day. With this, the BP came down to lie around 50th centile for his age and height. Next slide. Intraoperative management of hypertension. The child was given the last oral doses of antihypertensive medications early in the morning on the day of surgery. Plan in case of intraop hypertensive episodes was to start intravenous infusion of sodium nitroprusside at 0.5 to 5 microgram per kg per minute, and dose to be adjusted every few minutes to maintain normal blood pressure, and to avoid drugs which can stimulate catecholamine release or drugs which can cause parasympathetic blockade and cause tachycardia. The child underwent, next slide please. The child underwent laparoscopic bilateral cortical sparing adrenalectomy on day 15 after admission. Plan was to give intra-op glucocorticoid coverage if unexpected bilateral adrenalectomy was necessary, but this was not required. And also there were no major fluctuations in blood pressure, and the child did not require any additional antihypertensives during the intra-op course. Here is a picture showing the right intra-op picture of the right cortical sparing adrenalectomy. The first image shows identification of the lesion with the liver at the right top right corner, the gallbladder at the right bottom corner, and the second image is that of separating the cortex from medulla and preservation of adrenal vessels and specimen retrieval. Next slide shows the image of gross specimen of the lesion, both the right and left lesion, showing congestion on the external surface. The cut surface was yellowish in color with focal areas of congestion. Next slide, please. On histopathology, adrenal tissue with a well-circumscribed neoplasm composed of polygonal cells arranged in nests, as I've depicted in the red marking, was present, and some cells showed moderate to marked pleomorphism. No atypical mitosis, capsular or vascular invasion, necrosis, or periadnexal adipose tissue invasion was present. This histopathology slide is given a score of PASS 2. So PASS score is something which is used to tell whether the tumor has a malignant or aggressive behavior or not. A score more than 4 is suggestive of malignancy or aggressive behavior. A score less than 4 is suggestive of benign lesion. Next slide. Following surgery, the child was oral antihypertensives were gradually tapered and stopped over the next 2 weeks, and 24-hour urinary norepinephrine and metanephrine levels were measured 2 weeks after surgery, and they were found to be within normal range. Next slide. As this was a case of pediatric bilateral adrenal pheochromocytoma, sample was sent for clinical exome sequencing, and a mutation in the VHL gene was found, which was found to be pathogenic. So this was finally diagnosed as a case of von Hippel-Lindau syndrome with bilateral pheochromocytoma. Von Hippel-Lindau syndrome has two types. Next slide, please. Type 1 and type 2 with subtypes within each type. And this particular mutation, where in the 84th position, valine is replaced by lysine, is suggestive of type 2C VHL mutation. So they have increased risk of pheochromocytoma, high risk of pheochromocytoma, and low risk of CNS and retinal hemangioblastomas. So the further plan for this particular child was to check annually 24-hour urinary excretion of fractionated norepinephrine and methanephrine, or plasma methanephrine's and normepinephrine's, and genetic testing of first-degree relatives of the patient. Thank you.
Thank you, Meghna. That was an excellent presentation. So I think some key takeaways from your case is that one is that children typically present with sustained hypertension, but also headache, sweating. These are common manifestations. Apart from that, rarely some kids also present with polyuria, polydipsia, or they may present with visual symptoms. So again, in children, bilateral is more common, and genetic mutations are, now as we learned from Dr. Christina also, now everybody, all children should be screened for genetic mutations. So Meghna, can you tell me that what are the differences in the type of catecholamines secreted by adrenal versus extra-adrenal, like Pheo versus Paragangliomas? Is there a difference in the catecholamine secretion?
Yes, Fab. Pheochromocytomas usually secrete epinephrine and norepinephrine, whereas paragangliomas predominantly secrete norepinephrine or sometimes dopamine as well.
Yes, and besides that, if there are, if the involvement is of the parasympathetic chain, that is head and neck, PGLs, then they typically do not secrete anything, and they would present with mass effect. Similarly, if it is just a dopamine secreting paraganglioma, it may also just present with a mass effect. So norepinephrine was the predominant catecholamine in your case. So that itself is also, like, if you see the algorithmic approach for genetic testing. So an adrenal condition with predominant norepinephrine secretion, you have to first think of VHL. So it was good that you got VHL in your patient. So one more question to you is, like you mentioned that pre-operatively, you first gave him alpha blockade and then later on beta blockade. So is there anything else also that you have to take care of when you give alpha blockade to a patient? And which alpha blockers are available in India to use?
We have to ask the patient to take a high salt diet to avoid postural hypotension, and alpha blockers available in India, ma'am. I'm aware of prazosin, and I'm not sure about other drugs, ma'am.
So we have phenoxybenzamine and prazosin. So if a patient is put on phenoxybenzamine, then the problem is that it has a long-lasting effect. So before the surgery, like at least 3 days before the surgery, it is better to shift the patient to prazosin, because otherwise post-operatively the patient will continue to have hypotension because of the longer effect of phenoxybenzamine. And besides, when the patient is put on alpha blockade, one, you rightly said, increase salt intake, so at least 6 to 10 grams of salt every day, and 50% more than the normal maintenance. You have to give for at least 3 days prior to the 2 to 3 days prior to the surgery. And beta blockade you give to take care of the tachycardia. So I think you very well covered the intra-op management also. So we can see if there are any questions. You can also see from your end. So yes. How do you differentiate between renal and endocrine cause of hypertension and plasma methanephritis? Would you like to answer that?
Ma'am, could you repeat the question?
So one question is that, yeah, how do you distinguish between renal and endocrine cause of hypertension?
Renal causes usually, history-wise, they will have history of periorbital puffiness if it is an acute renal cause, water retention, history of hematuria, or other symptoms related to the renal etiology, whereas adrenal causes will have, depending on what is causing the, endocrine causes, depending on whether it's catecholamine excess, clinical features can be present in the form of sweating, tachycardia, hypertension, and if it is mineralocorticoid excess, there may be ambiguous genitalia, and if it's glucocorticoid excess, history of drug intake or presence of other Cushingoid features in the child with increased excess weight gain in clinical features. And investigations, if it's a renal parenchymal cause, renal function will obviously be abnormal.
Also, I think mentioned that. Yeah, hypokalemia is mentioned. If you're thinking of a mineralocorticoid or a renovascular hypertension, then you can have hypokalemia. Yeah.
Yes, ma'am. Yes. Abnormal renal function and urine analysis will show the proteinuria or presence of RBCs, and on ultrasound abdomen, the renal picture will be, there'll be altered echo pattern of the corticomedullary junction, and in adrenal cause, the mass, like any adrenocortical or adrenomedullary mass may be present.
Okay, there's one question by Dr. Sukanya. So she's asking, did you send the adrenal tissue sample also for genetic analysis? And would that help, or is it really required?
No, ma'am, we didn't send any adrenal tissue sample for genetics, and I'm not sure if it would help. I'm not aware of it, ma'am.
If Dr. Christina is there, if she could answer this, is there any rule of sending the adrenal tissue sample?
Can you please repeat the question? So sorry.
Yeah,
what is the question?
Yeah, there is a question that should the adrenal tissue sample be sent for genetic mutation analysis?
Yes. We always do that. We have a great deal of patients with somatic mutations. And not only that, there are somatic mutations like ATRX that they are aggressive. So that tumors have an aggressive phenotype and high risk of metastatic disease. And we should be aware of that. So whenever it is possible, always do an analysis in the tumor tissue and try to look for somatic mutations, because some of them are very important and have been repeatedly associated with recurrent metastatic and generally aggressive disease. So I would definitely advise that if it is possible.
Dr. Christina, probably this question is a little more specific. In a patient who has a PPGL with a known germline mutation, for example, this patient had a VHL mutation. So would you still like to send for somatic mutation?
Yes, we still send. We have several patients with specific germline and additional somatic mutations. If you ask me which one prevails, I do not have the answer, but if I see a very, very dangerous somatic mutation, then I would be more alert. VHL, we said before, it's not so metastatic as STH, but there is a 12% prevalence of metastatic disease, which for metastasis is not something that we should discount. So if I have also somatic mutation, I am not aware exactly how this can be. I'm not aware, I don't have the experience to tell you the outcomes, but I am much more alert. So yeah, I always send the tumor tissue for analysis of somatic mutations. If it is possible, I know that it's not always possible, but we always send it.
Just a simple question, maybe from an ignorant point. So how would you transport specimens, the adrenal specimens for mutation analysis? Is there a specific reagent in which the specimen should be sent, particularly for your succinate dehydrogenase mutations?
This is a question. So we have a standard operating procedure of how we send the specimens, and I can send it to you because I am not quite aware of how we do it. But I don't think it's too complicated. And we can also do that. But I will now try to share you the SOP. I will find it and I will share it in the chat, because we have a specific the specific SOP, and I don't want to tell something that it's not correct 100%.
I had a question for Meghna. So Meghna, your patient underwent bilateral endolectomy, though it was a cortical sparing. So did you measure the cortisol after the surgery, ensure that the glucocorticoids were preserved?
Yes, we measured serum cortisol after surgery. It was normal. And he
Right.
has come for follow-up twice after that. And during the first follow-up, we again measured serum cortisol levels. It was normal, sir.
Right. So that's good that he had a good cortisol. It was a nice surgery. But how confident before the measurement that your surgeon is definitely going to spare cortex? Because like nearly around 40% of the intended cortical sparing surgery could be disastrous. They may not be able to save a good cortex that could provide adequate glucocorticoids. So was it not a wise decision to provide the perioperative glucocorticoids and stop it maybe after a third or fifth day and then reassess the cortisol?
Yes, sir. The plan was, if they felt that the cortex is not well preserved, the plan was to start IV glucocorticoids immediately. But the surgeons were pretty confident, so we did not start. Maybe it would have been wiser to
sometimes they may leave a tissue, but may not be the intact vascularity. So, but I always prefer, even if it's a cortical sparing, better to cover up in the perioperative period, not to have any major disastrous events around. And again, stop glucocorticoids maybe on day 3 or day 5. You can check the cortisol and then make sure the cortex is functioning, and then discontinue the supplementation. Thank you.
Okay, thank you so much. Thank you so much. That was a fantastic session. Thank you so much, Dr. Christina, Dr. Vijay Sarthi, Dr. Meghna. Your presentation was brilliant and it was very, very useful. I think the whole session went very well. Thank you, Dr. Christina, and we hope you can continue to stay with us for the next part of the session too. And please give your inputs also. Thank you so much. And thank you so much. And I will take this opportunity to welcome Dr. Anurag Bajpai, who's known to everyone in India. He's one of the very, very active pediatric endocrinologists with a deep interest in research in several areas, including obesity, metabolic disorders, and he's trained so many students, and all of them have excellent outputs in terms of their research also. And it's a privilege to introduce Dr. Anurag Bajpai to you, and Dr. Anurag will take the session forward. Thank you so much, Anurag.
Thanks, Dr. Ahila, and congratulations to the entire ACES team for this wonderful session. It's been a wonderful session for the last couple of years. It's really gone leaps and bounds. And we were really intrigued by the cases and the new developments happening in terms of pheochromocytoma. I'd also to thank Dr. Christina and Dr. Meghna and Dr. Vandana for providing some valuable insights, which will continue forward in this interesting case, which we'll be presenting also from that perspective. So
thank you. I'm so to thank Dr. Vandana. Thank you, Vandana. I'm really, really sorry. Thank you so much. In spite of your travel, you helped us so much. Thank you so much.
Thank you for making me a part of it. Looking forward to the next session too. Thank you, Dr. Ahila.
So we have really seen how interesting and intriguing cases would be from in terms of initial evaluation to reaching a diagnosis for a perioperative management and long-term follow-up. Continuing the series further, we have another interesting case which Dr. Harish will be presenting from AIIMS Bhopal. And this again is an interesting case which will form the basis of further issues with regards to management. So we've discussed a lot about diagnostics. After this case, Dr. Vijay Sarthi will talk a lot about the management and advances in that regards. So over to you, Dr. Harish.
Am I audible, sir?
Yeah, you're audible. Please share the screen.
Yes, sir. Is my screen visible, sir?
Yes, yes. You can start now. Yeah.
Good evening, respected dignitaries. I'm Dr. Harish Kadri, pursuing my post-graduation in AIIMS Bhopal, Department of Pediatrics. Tonight, I would be discussing about a case of pheochromocytoma and paraganglioma leading to hypertension emergency in a child. Firstly, I would like to start off by thanking Dr. Anurag Bajpai, sir, who has been my moderator and helped me throughout the presentation. I would also like to extend my thanks to Dr. Shekha Malik ma'am, HOD Pediatrics at Department of AIIMS Bhopal, and Dr. Mahesh Maheshwari sir, my professor and consultant in charge, who have encouraged me to take up this case and guided me in the management. Coming to the case discussion, here is a child H of age 4 years, male. He is a resident of Bhopal, Madhya Pradesh, India, belonging to upper middle class strata. Has presented to us with the complaints of on and off headache since last 1 year, episodes of excessive sweating since last 1 year, vomiting episodes since last 3 months, and he has had recent onset generalized tonic-clonic seizures 3 days ago. Coming to the detailed history, headache was since last 1 year. It was paroxysmal and episodic in nature. It was moderate to severe in intensity, and it wouldn't subside even upon taking an analgesic. Vomiting usually associated with the headache, and it was non-bilious, non-bloody, and non-projectile. He has also had history of hyperhidrosis since last 3 months, associated with heat intolerance, and there were recent onset generalized tonic-clonic seizures with loss of consciousness, and which have lasted just for a few seconds. History continued. This child was managed in an outside hospital as a seizure disorder with raised intracranial pressure and has been given anti-epileptic therapy, following which the seizures have aborted, but the child was diagnosed to have hypertension and was referred to our center for further management and workup. So coming to the negative history that we ruled out, there was no history of fever, blurring of vision, irritability, or any postural abnormalities. No history of any neck swellings or significant weight loss noted. There's no history of muscle cramps or paresthesias or tremors. No history of abdominal distension, jaundice or bleeding manifestation. No history of any drug or toxin ingestion, and there's no history of trauma. Coming to the past history, there were not similar complaints in the past, and there was no previous hospital admissions. The family, there's no one in the family who has had similar complaints, and there is no early onset hypertension in the family. And coming to the birth history, the child didn't had any history of birth asphyxia. The antenatal events were smooth and normal, and the postnatal events were also normal. Coming to the examination, the child was conscious, alert. His pulse rate was 144 per minute. He was tachycardic, and his pulses, but the pulses were well felt and the peripheries were warm. Respiratory rate was 32 breaths per minute, and 4-limb blood pressure was taken using oscillometric method. The measurement in the right upper limb was 159 by 198 millimeters of mercury. In the right lower limb, it was 164 by 100 millimeters of mercury. In the left upper limb, it was 156 by 95. And in the left lower limb, it was 156 by 96 millimeters of mercury. And all the values and recordings were more than 95th plus 12th centile for the age and height of the child. And his temperature was 98.6 degree Fahrenheit. Coming to the anthropometry, the child was weighing 15.8 kilos, appropriate for the age, and his height was 106 centimeters, which was also appropriate for the age. His weight was appropriate for the height, and his head circumference was within normal limits. Upon physical examination, the head-to-toe examination, there were no neurocutaneous markers appreciated, and there was no apparent thyroid swelling noted. And coming to the genitalia examination, the child is in the prepubertal stage, SMA stage 1. The systemic examination, his higher mental functions were absolutely normal. The cranial nerves were within normal limits. In the motor examination, he has a normal tone, normal power, and the reflexes is normal, and there was no focal neurological deficit observed. His sensory examination was also within normal limits. The respiratory and cardiovascular system were within normal limits, and upon upper abdomen examination, there was no organomegaly or no mass felt per abdomen, and there was no bruit felt upon auscultation. As I've discussed the history and the examination, now I would like to summarize this case. So this is a case of a 4-year-old male child presented with the complaints of episodic headaches associated with vomiting, excessive sweating, and recent onset tonic-clonic seizures. Upon examination, the child was found to be having unexplained tachycardia and hypertension in all the 4 limbs with a seemingly normal growth and development, and his general and systemic examination was found to be unremarkable. So a provisional diagnosis of hypertensive emergency was considered and managed. So the differential diagnosis that we thought of at the beginning of the evaluation were renoparenchymal and renovascular causes, as they are the most common cause of hypertension in children, following which we thought of hyperthyroidism or any catecholamine secreting tumor, including paraneoplastic syndromes, neurocutaneous syndromes, and monogenic forms of hypertension, considering the age of the child. So the emergency management which was done the hypertensive emergency was managed using IV labetalol infusion following a short-acting benzodiazepine, which was given to abort the seizures. And the infusion was stopped after 48 hours, following which we had put the child on oral antihypertensives. The blood pressures have significantly dropped, but it was still over stage 2, despite the child being on oral antihypertensives. So coming to the initial laboratory workup, the complete blood picture shows hemoglobin of 13.3, WBC was within normal limits, and the platelets were also normal. In the liver function test, the total bilirubin was normal, the transaminases were normal. The renal function was absolutely normal. There were no electrolyte disturbances. The coagulation study was normal. Random blood glucose was 80 milligram per deciliter. His blood gas was normal, within normal limits. Urine routine had no RBCs or no WBCs found. Following which we went ahead with a renal artery Doppler, which was again within normal limits. His echocardiography was done as a routine investigation in a case of to evaluate a case of pediatric hypertension, and it was within normal limits, and there were no structural changes found. Fundus examination was done, and there was no papillary edema nor any hypertensive retinopathic changes noted in the fundus. So this is I would like to show a small algorithm to evaluate a case of pediatric hypertension. So any case of documented pediatric hypertension, we need to first do we need to take a 4-limb BP measurement and look for the gradient in between upper and lower extremities. And if the systolic blood pressure is 20 millimeters of mercury between upper and lower limits, then we could actually think of causes like coarctation of aorta or any aortic arch abnormalities like interrupted aortic arch, and do the workup accordingly. If that is normal, then we need to look for the clinical signs of raised ICP and do a fundus examination to rule out the neurological causes of hypertension like ICSOL, hydrocephalus, or CNS infections. Following which we need to perform do a renal. We need to look at the renal parameters, and if renal function tests are abnormal or the imaging is abnormal, then we could think of causes like chronic kidney disease and acute kidney injury. And if there are predominantly WBCs noted in the urine microscopic analysis, then we could think of causes like UTI and reflex nephritis. And if there are predominantly RBCs which are noted, then we could think of causes like glomerulonephritis, vasculitis, and renal stones. After excluding these causes, then the causes that we are left with are renovascular causes like renal artery stenosis and fibromuscular dysplasias, endocrinal causes, and then monogenic forms of hypertension, and finally the primary or essential hypertension. So in our case, we have ruled out the renoparenchymal causes by doing a renal urine routine microscopy and renal parameters, and renovascular causes were ruled out after performing a renal artery Doppler. And in view of normal electrolytes and blood gas, we have ruled out monogenic forms of hypertension, and the gradient between upper and lower limb blood pressures was also normal. So we have ruled out coarctation of aorta, and in view of pulsating headaches, intermittent episodes of sweating and flushing, tachycardia, unexplained tachycardia, endocrine etiology was suspected, and we have worked up accordingly. So coming to the main topic, that is evaluation of endocrine hypertension. So after ruling out the renovascular and renal parenchymal causes, we need to take a detailed history, and a thorough physical examination has to be done. So in the history, the history paroxysms are important thing that is to be noted because of conditions like catecholamine secreting tumors, which actually happen like in paroxysms. And we need to look for genital ambiguity, like in variants of CAH might have genital ambiguity. And we need to evaluate family history for any early onset hypertension, and precocious puberty again points in favor of congenital adrenal hyperplasia. And we need to do a thorough physical examination. Anthropometry is the key. Muscle weakness has to be looked out for conditions where hypokalemia is predominant, like in monogenic forms of hypertension. We need to evaluate for abdominal and inguinal masses, and faces is again important, like in Cushy-Gord faces for the child who has been on long-term steroids. Following this, we need to do a routine endocrine workup. where we do a thyroid profile, serum electrolytes, blood gas, and plasma and urine metanephrines. So any abnormal blood gas or electrolytes, we need to suspect monogenic forms of hypertension and variants of CAH. And if we find metabolic acidosis and hyperkalemia in the child, then we could think of conditions like Gordon syndrome. And if there is metabolic alkalosis associated with hypokalemia, then we need to measure plasma renin activity and aldosterone. If the renin is low as well as the aldosterone levels are low, then we could think of causes like Liddle syndrome and AME. And also there are two variants of congenital adrenal hyperplasia, which also have low renin and low aldosterone activity, that is 17 alpha and 11 beta dehydrogenase deficiencies. So to differentiate this, we do a deoxycorticosterone levels, which are found to be high in case of alpha and 11 beta hydroxylase deficiencies. And if the renin activity is low, but the aldosterone activity is high, then we could think of conditions like familial hyperaldosteronism, like adrenal tumors, adrenal hyperplasias, and glucocortical remedial aldosterons. And if there are elevated metanephrines, then it's pretty much the straightforward case where we go ahead with the anatomical imaging studies and followed by functional imaging to rule out conditions like neuroblastomas, pheochromocytomas, or any other paraneoplastic condition. So the endocrine workup that we did in our case, we found the thyroid profile to be within normal limits. Plasma-free metanephrines were done, which was found to be 2,430 nanogram per liter. Which was way too much elevated, and following which
Harish, I would like to intervene. Is it plasma-free normetanephrine?
No, sir, it was metanephrine, sir.
We don't measure plasma-free metanephrenes, right? We measure plasma-free metanephrine separately and plasma-free normetanephrine separately. So here in this 4-year-old child, there is no way that metanephrine would be elevated. I believe that it should be plasma-free normetanephrine. Okay, please go ahead. Yeah.
Okay, sir. So, following which we have done a functional anatomical imaging where we went ahead with the CECT abdomen plus thorax. So we could see a well-defined oval heterogeneously enhancing soft tissue lesion in the right suprarenal location. And there was another similar lesion which was noted in the left para-aortic region. So a small slide here to summarize the differences between urinary and plasma metanephrine. So the prerequisite in urinary metanephrine is a 24-hour urine collection, which is better than a spot urine collection. And in a plasma metanephrine, we actually have to have the child in the supine posture, and there should be an indwelling catheter which is placed 20 minutes prior to the sample collection, and the child should be made to fast overnight. So the cutoffs in urinary and plasma are as follows. In the normetanephrine is more than 900, and if metanephrine is more than 400 micrograms, and in plasma metanephrine, so the metanephrine is more than 57 picogram per liter, and normetanephrine is more than 148 picogram per milliliter. The sensitivity of urine metanephrine is 96 to 100%, and the sensitivity in the plasma metanephrine is the same. The specificity of urinary metanephrine is 95%, the plasma metanephrine is 90%. There's a false positivity. We tend to see a lot of false positivity in plasma metanephrine, whereas we don't see this in urinary metanephrine. So how do we interpret these reports? If fractionated plasma or urine metanephrines, if it is normal, then we just monitor and we evaluate the other causes of hypertension. And if it is more than 4 times the upper limit, we go ahead with anatomical imaging followed by functional imaging and genetic studies. And if it is inconclusive or equivocal, then we repeat the test, and if the repeat value is negative, then we monitor the child, and if it's positive, then we take the other limb. So the further course is the child after anatomical imaging studies has been diagnosed with right pheochromocytoma and left extraadrenal paraganglioma. Following which we have started the child on an alpha blocker prozosine, which is a selective alpha-1 blocker, and the dose that he has been started on was 1.1 milligram per kg per day, and we had given this dose for first 3 days, and we started titrating the dose, and the clinical parameters that we have looked for were nasal congestion and postural hypertension and reflex tachycardia. to see whether the child has had enough alpha blockage. So the child had enough alpha blockage after titrating the dose to 0.4 milligram per kg per day, and we have achieved this on day 12. Following which, we had put the child on a beta blocker. Propanolol was given at a dose of 1 milligram per kg per day to prevent reflex tachycardia and postural hypertension. And prior to the surgery, we have given a saline load. As we know that conditions like in catecholamine secretory conditions, because of sustained constriction of the vessels, the intravascular volume is going to be low. So the patient might have hypotension later. So for that, we actually give a saline. And following which, we the surgery took place, and the right suprarenal tumor excision with the right partial adrenalectomy and with the left para-aortic tumor excision. In the intraoperative course, there was one reading of high blood pressure, which has been managed by giving a controlled, which is continuous sodium nitroprusside infusion. The gross findings were on the right side. The right-sided lesion, we found a capsulated soft tissue, which measuring 1.5 into 1.5 into 1.3 centimeters, and the cut surface was yellowish with red solid homogeneous, and it was non-necrotic. On the left side, it was again capsulated tan-colored globular soft tissue measuring 1.1 into 1 centimeters, and the cut surface was yellowish red solid homogeneous with no hemorrhage or necrosis. Here we could see a nice round, well-defined solid lesion. This is an intraoperative image of the right side at our setup, and it's a nice rounded, well-defined lesion, not extending to the adjacent structures. And this is the pheochromocytoma, which is labeled. And this is the pheochromocytoma and paraganglioma again. And the microscopic findings, we had seen a nested pattern of the promorphine cells, which is characteristically called the Zellballen pattern, and with thin fibrous septae. Round to oval tumor cells were seen with stippled nuclei and with granular cytoplasm and inconspicuous to prominent nucleoli. So this is the microscopic view on H&E staining. We all could appreciate here a nested appearance of chromaffin cells, that is the Zellballen pattern of pheochromocytoma, and a similar pattern is also seen in the paraganglioma. So post-surgery, the blood pressures were within the normal limits, and the child has been discharged with advice to undergo genetic testing in view of syndromic causes of pheochromocytomas and paragangliomas. So I would like to conclude this by giving a small message. Endocrinal hypertension is uncommon in children, and most of them were associated with endogenous hormone protection. Hence, pediatric hypertension, when diagnosed, it is prudent to rule out the other etiologies before jumping onto the endocrinal causes. Paroxysmal and episodic attacks, along with unexplained tachycardia, palpitations, sweating, should always raise the suspicion of sympathetic overactivity and endocrinal causes. A strong family history of hypertension increases the possibility of endocrine and monogenic forms to be the causative factor for hypertension. Thank you.
Thanks, Dr. Harish, for the wonderful presentation. And you've taken through a very specific and a challenging case in terms of diagnosis and management. Again, highlighting that we do have a delayed diagnosis as 1 year had passed for the symptoms to happen. And often, while we talk about paroxysmal symptoms, we talk about the other symptoms. The usual presentation, unfortunately, of PO in this age group is in the form of a hypertensive emergency. And that's something which is unfortunate, that the blood pressure is either not measured or has been attributed to some other causes in that regard. So while we are waiting for questions which are coming here, how did you manage the adrenal insufficiency part in the initial phase post-operatively? Like the coverage, the stress dosage, and other aspects?
So there was one adrenal gland which was completely intact, sir. So we didn't have to give any extra drug to take care of the adrenal insufficiency. Yeah, I think this was just to address the various the specific question on that regards. Now, how do you propose to follow up the child? Frequency and the monitoring schedule, and what you like to monitor on follow-up? Sir, we have advised the child to come to the follow-up after 2 weeks post-surgery. And now I think in another 2 or 3 days, he might turn up in our OPDs. So that is still awaited, sir. And we have advised the child for a genetic testing. I think that's very important, because we've already seen the very, very high prevalence of a genetic cause. So it's very soon syndromic association is there. And we have got this scenario very severe. We have to consider for a genetic possibility there in that regard. So
we can have some questions if they are there.
May I ask, sir?
Yes, Dr. Vijay, please go ahead.
Dr. Harish, what do you think is the underlying genetics for this patient?
Sir, this is not a case of bilateral pheochromocytoma. So I think this is going to be some case of pheochromocytoma and paraganglioma syndrome. Now, I may not be able to comment on which PGL.
So indeed, like this combination could be seen with SDH rated group.
Yes, sir.
But see, we have to give a weightage here for the age. So in fact, like but by 4 years, usually none of the SDH rated PPGL would present. It's typically the VHL which presents by that age.
Okay,
and
sir.
Secondly, like in fact, like if you look at our KM cohort also, even almost all PCC PGL pediatric patients who had one PCC and one PGL, or even two PCC with one PGL, they were all VHL. So Indian cohort is a bit different, especially with respect to VHL, to have this combination of one PCC and one PGL. Indeed, we have also seen somehow these group of patients are also more likely to have more of a type 2A or type 2B phenotype with some other tumors. So it also tells that probably, unlike the previous case, which was actually typically 2C, here we may also have to look for the other components of VHL, so including angiomas, hemangioblastomas, and PNETs, as well as the RCC.
Okay, sir.
I think that's a very, very important finding, because our job does not end by just making a diagnosis of pheochromocytoma, and we are just awaiting genetics. And I think this will be an interesting thing to look at, because that will really decide about long-term management, long-term assessment, and follow-up. So I think overall, this was a very interesting case. And if we don't have a questions now, we can take it up after Dr. Vijay's presentation is there. So I would now like to introduce Dr. Vijay, who really doesn't need an introduction, and he's been working in the field of pediatric endocrinology for a long time. He's currently working as a professor and head of endocrinology at Vaidehi Institute of Medical Sciences and Research Center, Bangalore. And he has been a bright star in pediatric endocrinology. I remember the PET school, which was there, I think 15 years ago, and he was there in that time. He's really grown leaps and bounds in different fields, and he has a lot of accolades which were there. He being a best resident doctor at KM Mumbai, best research methodology, endocrine tumor symposium as well, and huge number of publications in national and international journals. Pheochromocytoma, paraganglioma clearly is close to his heart, as we'll see him talk, and he has been doing a lot of work on that regards. Plus, he is intrinsically involved in setting up guidelines for type 1 diabetes, both from ICMR and ISPAE. So, Dr. Vijay, we look forward to your wonderful session on the management aspects of pheochromocytoma. Over to you, Dr. Vijay.
Thank you, Anurag sir, for the kind introduction. At the outset, I would like to thank Dr. Ahila and the ISPAE ACES team for giving me this opportunity. Indeed, it's a great privilege and a proud moment to share the program with Dr. Christina, who is a legendary lady in the field of PPGL. It's also my duty to thank the Department of Endocrinology, KM Hospital, and St. G.S. Medical College. Indeed, whatever the interest, knowledge, or experience I have in PPGL is all the courtesy of Department of Endocrinology of KM Hospital. So my sincere thanks to Dr. Nalini Shah, Dr. Tushar Bangar, and Dr. Anurag Leela, who are my mentors in the field of PPGL. So with this, let me talk briefly on the characteristics of PPGL. Indeed, the majority of the content of my talk has already been discussed in various previous sessions. So, but still, I would like to continue this. It's going to be a recap and definitely going to add up to the previous discussions. So indeed, as Dr. Christina mentioned, 1% of the hypertensive children will have pheochromocytoma as an etiology. Indeed, we are all aware of the 10% rule we had maybe before 2003 or 2005, which used to say that 10% of the tumors are in children, 10% are metastatic, 10% are bilateral, 10% are extra-adrenal. And so, indeed, like very few of these 10% really hold good now. Indeed, like it was really called as a death of an axiom in 2003 by Newman, when they identified a larger proportion of genetic etiology, a larger proportion of extra-adrenal, and so on. Indeed, like especially when it comes to children, definitely this 10% rule does not hold good. But there are only two areas probably it still holds good, that the 10% are still pediatric. It's not a higher number than 10%. And the second one is 10% are metastatic. Indeed, in 2017, I published this 10 to 90% rule, just to summarize, based on the data which was available by then. That goes like this: the 10% as malignant, 20% as synchronous bilateral, 30% are extra-adrenal, 40% as familial, 50% recurrence by 30 years, 60% as boys, 70% having sustained hypertension, 80% having germline mutations, and 90% being secretory. As the data is evolving over time, a larger data is coming in. So we do have some modifications for these rules, so which I'm going to discuss here. So the one rule which still holds on is that 90% present as with symptomatic presentation, whereas only 10% will have an either incidental presentation or detected as a part of family screening. So this holds good. The second one is slightly modified. Initially, the earlier papers had a higher history of familial component, but the recent studies are slightly reduced in number. The family history may be available in around 25%, whereas another 5% may have a syndromic association by the time of presentation. So when they present for the first time to us, around 30% will be familial syndromic, whereas 70% may be apparently sporadic without any clues of family history or the syndromic components. Right, let us look at the secretory phenotype. Indeed, it was discussed previously. So the majority of the tumors are secretory, that may be 90%, whereas 10% may be non-secretory. If you look at the further division among this 90% of secretory, 10% are actually epinephrine secreting, whereas 80% are norepinephrine secreting. As Dr. Christina addressed aptly, majority of these tumors belong to the cluster 1 etiology, and hence they are norepinephrine secreting. Right, so let us look at the secretory phenotype. As Dr. Vandana was mentioning already, the HNPGL are the ones which arise from the parasympathetic ganglia, and hence they don't have the operators for synthesis of at least the functional catecholamines, and hence they're usually non-secretory, and they don't produce any catecholamine excess symptoms. Nevertheless, around 20 to 25% may have an elevated dopamine metabolite, that is methoxytyramine. Whereas if you look at the thoracoabdominal sympathetic paragangliomas, they do have a machinery to synthesize norepinephrine, but not the epinephrine, and hence they're typically norepinephrinergic, but a proportion may be only isolated dopaminergic, whereas another small proportion may be non-secretory, but majority, I would say around 80 to 85% will be norepinephrinergic. Moving on to the adrenal tumors, there is pheochromocytomas. They could be either norepinephrinergic or epinephrinergic. Again, what decides an adrenal PCC to be norepinephrinergic or epinephrinergic? Again, it is the underlying genetics. If it's a cluster 1 tumor, they're typically norepinephrinergic tumors because they don't have PNMT. Whereas the cluster 2 tumors, that is those associated with the RET and the NF1, they're typically epinephrinergic. And indeed, these epinephrinergic tumors are much rarer in children because the contribution of RET and NF1 for the pediatric PPGL is pretty small. So, of course, it's probably a local information to pass on to the Indian doctors who are dealing with the PPGL evaluation. Indeed, the Dr. Lalpath is the only lab which is offering the measurement of all the 3 COMT metabolites of catecholamines by LC-MS. So probably we can utilize this, especially when we're looking for the measurement of methoxytyramine, whereas other labs measure it by enzyme immunoassay. Even the HPLC measurement of the fractionated metanephrines is available by all the 3 labs. Recently, in fact, Anand Lab has also included 24-uri methoxytyramine in the measurement, but nevertheless, as Dr. Christina mentioned, probably 24-uri methoxytyramine may not be a very attractive investigation or plasma methoxytyramine. So let us look at the anatomical distribution of PPGL and children. Indeed, like around the adrenal tumors, when they're solitary, maybe around 45%, whereas the bilateral adrenals, which are synchronous, may be seen in around 15% of the patients, whereas a coexisting PCC and PGL, which is relatively higher in Indian setting, would be seen in around 10% of the patients. whereas an exclusive extra-adrenal PGL would be present in around 30% of the pediatric PPGLs. So if you look at any adrenal tumor, it will be around 70%, whereas any one PGL, if you take, it will be around 40% of the patients. Indeed, if you look at the anatomical distribution of the extra-adrenal PGL, out of that 40%, the majority will be extra-adrenal abdominal tumors, whereas only the remaining 10% would be extra-abdominal. They may be either in the head and neck, or in the thorax, or rarely in the pelvis. This is how the proportion of PPGL are distributed in the pediatric group. Indeed, the synchronous metastasis may be seen up to around 8% of the patients in the pediatric PPGL. The common lesions, as we could see in our KM study, are skeletal, or the mesenteric lymph nodes, or the lung, or the liver. So let's move on to the germline mutation prevalence. As again already highlighted by Dr. Christina, 80% of the PPGL will have underlying germline mutations, whereas 20% may not have any mutations. Indeed, these 20% may also have yet unknown mutations, or at least the somatic mutations. Indeed, 100% of the pediatric PPGL would have some amount of genetic etiology. If we divide the 80% of the germline mutations into individual genes, the majority of them, that's 55%, are VHL, whereas another 25% are in SDHB, maybe 10% in SDHD, 5% in RET, and maybe others in 5%. So we know that almost 80% are done by VHL and SDHB, and 90% of the general mutations by the VHL, SDHB, and SDHD. So whether the PPGL location differs by the genotype, yes, of course. If you take the VHL, it could be either solitary adrenal or could be synchronous bilateral PCC. Indeed, if we have a patient with a synchronous bilateral PCC, for all practical purposes, it's a VHL. But they also have a good proportion of patients who can have a extra-adrenal abdominal PGL, whereas the abdominal PGL, whereas the extra-abdominal PGL are usually rare in patients with VHL. If you look at the distribution of PPGL and SDHB, they're predominantly abdominal PGL, whereas sometimes they may also have a thoracic SPGL. A good proportion of patients may also have adrenal PCC, even in SDHB, whereas a small proportion may also have a HNPGL. Whereas if we look at the PPGL location in SDHD, they're predominantly HNPGL, but a good proportion may also have an adrenal. Indeed, in the German cohort by Newman, few of them also had a bilateral PCC. In addition to that, they may also have some thoraco-abdominal sympathetic paragangliomas. If you look at the RET mutations, it is typically adrenal. Indeed, the extra-adrenal tumors are extremely uncommon in patients with MEN2A or MEN2B. And quite often they could be bilateral, but in pediatric age group, they're literally unilateral. Whereas if we evaluate them in their third or fourth decade, they're quite often bilateral. And if you look at the secretory phenotype based on these genes, the VHL, SDHB, and SDHD are either norepinephrinagic, dopaminergic, or non-secretory, whereas the RET-associated ones are typically epinephrinagic. So indeed, this is a study by Dr. Christina, and did a very nice study. I think a glimpse of it she already mentioned. Indeed, it teaches us about the behavior of the PPGL across the ages, not only in the pediatric age group. The points to learn here is that the pediatric PPGLs are multifocal. So not only like bilateral, could also be having tumors simultaneously existing or metachronously having a PCC with PGL, it may be SPGL or HNPGL, or sometimes HNPGL may be multiple. So they're typically multifocal tumors. Whereas if we look at the solitary tumors, in the first decade, they're predominantly solitary adrenal, whereas in the second decade, they're predominantly solitary extra-adrenal tumors. But however, after 30 years of age, again, it's predominantly solitary PCC more than that of the solitary PGL. Again, the hereditary component is much higher in the younger age group. As the age increases, the contribution of hereditary disease comes down. Among the hereditary, it's predominantly cluster 1 mutations in the initial few decades. So as the age increases, cluster 2 mutations take up a larger proportion, though cluster 1 mutations still remain the major cause. Again, the secretory phenotype, they're predominantly noradrenergic in the younger age, whereas the larger proportion are adrenergic in the older age patients. So let's move on to the imaging part. So indeed, like if you look at the sensitivity of the anatomical imaging in our study, so the CT had a 100% sensitivity for primary PPGL, whereas it had around 80% sensitivity for the metastasis. The MIBG, which is a commonly done investigation in Indian setting, at least in the past decade, has a lower sensitivity both for primary PPGL as well as for the metastasis. But let me highlight, like when compared to the outside India studies where they use a MIBG SPECT CT, what we are using is only MIBG whole the planar scan. So that's maybe the reason why we have a much lower sensitivity with the MIBG scintigraphy. Whereas the FDG PET again had a good sensitivity for metastasis, but not for the primary PPGL. Whereas the dotted PET CT had a good sensitivity for both primary PPGL as well as for metastasis. So for all practical reasons, especially when we don't know the underlying genetics, so it's always good to go with the dotted PET CT to evaluate for multiple PPGL as well as for metastasis. Another interesting character of the PPGL is the intense arterial enhancement, either on the CT or on the MRI. Unlike the ACC, the adenocortical carcinomas, probably when we have an adrenal tumor, when we are not very sure about whether it's an adenocortical carcinoma or a Pheo, if there's an intense arterial enhancement, we know it's more likely to be Pheo. The similar phenomenon is also seen with the sympathetic paragangliomas. However, the limitation of this tool is that the cluster 2 related tumors like MEN2A and MEN2B ones may not manifest this, but nevertheless, these are a small proportion in pediatric PPGL. As Dr. Christina mentioned, the very classical sign on MRI is the light bulb sign on T2 weighted images. It's a very specific sign, but let me tell you, this is not a very sensitive tool. So only 50% of the PPGL patients will have this sign. So once we have localized it, it's now to manage the patient. So typically, as discussed in both the cases, we use alpha blocker and high sodium diet to start with. If BP is well controlled without any intolerable side effects, and we can consider adding a beta blocker if the tachycardia is there. If no tachycardia, there is no need to add a beta blocker. Once the complete alpha blockade is done, we can go ahead with the surgery. But if alpha blockade is not giving a good control of blood pressure, or it's giving any intolerable side effects, calcium channel blockers remain a good alternative to, for the preoperative blockade. But the real problems occur when probably we're managing some unique situations like a pheochromocytoma existing with a cyanotic heart disease. Indeed, this is the patient who pushed us to use amlodipine in this patient, because whenever the prazosin was started, even at a smaller doses, the patient was having recurrent cyanotic spells. But when the patient was treated with amlodipine, there was a very good control of blood pressure without worsening of the cyanotic spells. So after this learning curve, indeed, we decided to do a the pilot randomized control trial to compare amlodipine versus prazosin in adult patients with PPGL. So this was the protocol we used on every daily basis. The dose of either drug was escalated to reach a good BP control. Once the BP control was achieved, the patient was started on beta blocker. And if BP was not controlled, other drugs like clonidine were used. And the previous day, the patient was given saline infusion to prevent the postoperative hypotension. And when we looked at the data, there's a glaring difference that the hemodynamic instability was significantly higher in patients who received prazosin when compared to those who received amlodipine, in whom there was a stable blood pressure levels which were maintained. To quantify this, there was a great decrease or a lower amount of hemodynamic instability with amlodipine when compared to prazosin. It's not only with respect to the hypertension, but even the hypotension episodes were significantly lower in patients who used amlodipine. So next question comes whether to do a cortical sparing adrenalectomy in patients who are having a bilateral PCC, or even having a unilateral PCC, but we know very well that there's going to be a hereditary tumor with a high possibility of recurrence on the contralateral side. In those patients, So what is the advantage and disadvantage of doing a cortical sparing adrenalectomy? Indeed, this is the adult data, but this gives us a very useful information that whenever the cortical sparing adrenalectomy has been tried and successful, the chances of recurrence are much higher, almost around 10%. Whereas the total adrenalectomy is done, the chance of recurrence are much lower on the ipsilateral side. But another learning point here is that in those patients who were intended to have a cortical sparing adrenalectomy, but could not achieve a glucocorticoid adequacy state, indeed, they also did not have a good, they did not have a higher recurrence rate. It means that if the cortical sparing adrenalectomy is not successful, that means they have completely removed the medulla. So that's another important point. So once the patient has undergone surgery, the next important point is to follow up the PPGL. We need to document the cure. And typically we do with the clinical examination by measurement of blood pressure. But let me tell you, if there's a long-standing hypertension, the blood pressure may continue to remain high for a while, maybe for a few weeks to a few months, because of the permanent changes in the arteriovascular media that increases the arterial stiffness. So in that is the case, we can restart the patient on small doses of calcium channel blockers and gradually tapered off over time. But the biochemical cure also need to be documented by measuring either plasma-free metanephrines or 24-hour urinary fractionated metanephrines. But in patients who had an isolated elevation of normetanephrine, let us say in both the patients, so even just measuring the plasma-free normetanephrine in the postoperative period as well as in the follow-up may make the approach cost-effective, especially for the Indian setting. So looking at but the patients may also have a persistent disease. So it could be in patient where there's an inoperable primary, we never tried to attempt to do a surgery, or when there was an attempt to do a surgery, but there was an incomplete resection, especially when we are trying to do a cortical sparing surgery, or when there is a synchronous metastasis already, even if you remove the primary, there could still be metastatic tissue which may be functioning. So in these cohort of patients, we need to look at for the progressive disease, or in those who have achieved a cure, we need to closely follow them, that group also, because they may develop a metachronous metastasis, as Dr. Christina already mentioned. The metachronous metastases are much higher in pediatric PPGL, and they may have a local recurrence, especially if they would have done an incomplete resection when they are aiming for cortical sparing. And even the second PPGL chances at the other places, for example, on a contralateral side or at the ganglia, are also significantly higher, owing to the higher proportion of hereditary tumors in PPGL. It's not only that, the follow-up should also include the screening for non-PPGL tumors. For example, patients with VHL that are at increased risk for RCC, PNETs, or even the cerebellar hemangioblastoma or a renal angioma, so or even endolymphatic sac tumor. It's not only VHL, even in red, we have to look for the medullary thyroid carcinomas if the patient has not already undergone prophylactic thyroidectomy, or maybe for parathyroid hyperplasia as well. Whereas even in SDHB, we typically always look them as PPGL alone associated tumors. They may also have increased risk of renal cell carcinomas, pituitary adenomas, or even the papillary thyroid carcinoma. Though we don't typically screen for these pituitary adenomas and thyroid carcinomas, definitely if someone is coming with some related symptom or suspicion for these tumors should be higher in the cohort. So if you look at the outcome of these patients, again, data from Dr. Christina. So the overall survival, even at 15 years, is very good. But whereas the event-free survival is very minimal because they have either increased metastasis, which is metachronous, or it could also be increased local recurrence or a second PPGL. So another great data on the prognosis of pediatric PPGL patients is from Bosch et al. So this is another data from Dietersen, and they say that those who have a metastasis have a significantly lower survival outcome when compared to those who did not have a metastasis. So at least we know that those who have a metastasis have a significantly lower outcome. Indeed, if you look at the genotype-based survival is the lowest for SDHB. Probably again, it is accountable by the higher rates of metastasis in SDHB patients. But let me tell you as a probably Indian specific point here. So majority of our VHL patients actually had very aggressive PNETs, so which not very much reported in other VHL cohorts. So indeed, whatever the mortality we had in our VHL patients was because of malignant PNETs in our cohort. So again, if you look at the recurrence of a second PPGL, again, indeed, it's more driven by the hereditary. But what I would like to mention here is that the second PPGL risk is much higher in pediatric age group. It could be as high as around 30% by 10 years, or 40% by 20 years of follow-up, and around nearly 50% by 30 years of follow-up. So that's a very important need. Even if you're not suspecting a metastasis, at least for occurrence of a second PPGL, we should keep these patients in loop. So again, if you look at the frequency of second PPGL based on the genotype, it's highest for VHL as well as the SDHD. Indeed, probably the SDHD data from this cohort was slightly biased. It's typically from the Newman cohort. But whereas in other studies, the recurrence is much higher for VHL and followed by SDHB. And sporadic PCCs do recur, but it's relatively lower. But one point to learn here is that irrespective of the genetic etiology, for all the groups, especially for SDHD, VHL, and SDHB, the recurrence rate at around 6 years of follow-up is around 20%. As I mentioned earlier, if there's an incomplete resection thing, so there's a higher risk of recurrence. Right, so it's very, very important to follow up these patients for recurrence. Indeed, again, this is from Dr. Christina's paper that which is provided by the Cronan group, where they try to put some score to predict the recurrence risk. So if somebody is having an SDHD or SDHB, their chances of recurrence are higher, whereas VHL also has relatively higher recurrence. Whereas the R1 or R2 status of resection or a metastatic PPGL diagnosis, they also have a higher chance of recurrence. So, but even among the R0 ones, the non-HNPGL have a higher recurrence, whereas among them, those who are a little larger, that is, tumors were more than 5 centimeters for PCC, or more than 3 centimeters for the PGL, have a higher recurrence rate. So based on these features, you can give points, and somebody who have a higher points of 6 to 8 have the highest risk of recurrence. Probably the follow-up should be much closer in these patients, whereas those who have around 3 to 5 points also have a higher recurrence. So you can have a modestly aggressive follow-up. So another important point probably we found in our study, which I would like to mention, as an anticipation in VHL. We know that anticipation, when compared to the previous generation, the next generation is going to have an early and more aggressive presentation. Indeed, we had around 8 parent offspring pairs from 5 families. In all of them, the PCC is the initial presentation. So the offsprings were much younger at presentation when compared to the parents. And the number of PPGL were higher, despite the younger age at presentation, the number of PPGL were higher in the offsprings, whereas the tumors were not smaller. Indeed, they were apparently larger in the offsprings, though they were not significantly larger, but at least they were not inferior, they were not smaller in size, indicating that there was a clear anticipation in VHL. So whenever we are translating, especially when you're seeing a adult patient with a VHL, so don't wait to put a screening protocol for their children till they become adults. Start screening them from younger age, because even though their parents manifest in the adulthood, their children may start manifesting in the childhood. So looking at the surveillance protocol on follow-up, so it's always that we should make a regular annual examination, at least to monitor the blood pressure. And plasma-free metanephrine or 24-hour fractional metanephrine should be done annually. And if you are looking for someone who is known to have an SDH-related mutation, ensure that the protocol also includes a measurement of methoxytyrine. So if it's an SDH-related gene, you should also do an MRI of the head and neck, thorax and abdomen and pelvis every 2 to 3 yearly, because we don't want to miss the biochemically silent tumors. And if it's a VHL, we need to do a dilated fundus examination every 6 to 12 monthly, audiometry to look for any systemic, this endolymphatic sac tumor annually, and every 2 yearly they should undergo MRI brain and spine with contrast, typically with a special focus on inner ear, again to look for endolymphatic sac tumor. should be done at least once in 2 years. And the imaging of the abdomen is preferably done with an MRI, but in young patients, maybe ultrasound or even really CT may be considered on a discretion and should be considered every 2 yearly. And imaging of the abdomen should not only focus on the PPGL, but also on the PNETs as well as the RCC. So for a RET mutation carriers, so look for the goiter, get a calcitonin and ultrasound neck. If the patient has not yet undergone MTC, as soon as the PCC resection is done, subject them for prophylactic thyroidectomy. If they already had a malignancy, definitely the patient would require multimodal therapy. It's also worth screening them for with serum calcium, phosphorus, as well as PTH to rule out primary hyperparathyroidism. To summarize, 90% of the pediatric PPGL are symptomatic or secretory, 60% are boys, 30% are familial or syndromic. If we look at the proportion of PCC PGL, 60% are exclusively PCC, 30% are exclusively PGL, whereas 10% may have a combination of PCC and PGL. Among the 60% of exclusive adrenal, 45% are unilateral and 15% are bilateral. Whereas among the total extra-adrenal 40%, 30% are abdominal, whereas the remaining 10% are extra-abdominal. And if you look at the germline mutations, 80% will have hereditary etiology. And again, 80% of these are accounted only by 2 mutations, that is VHL and SDHB. The pediatric PPGL patients have a high chance of recurrence either by local relapse or as a second PPGL or as a metastasis, and hence they require regular follow-up, not only for PPGL, but also for associated tumors. Thank you so much for the patient hearing.
Thanks a lot, Dr. Vijay, for this wonderful presentation and really summarizing a lot of experience that you have had with your team with regards to the pediatric experience for PPG. And in particular, the few points which really came up was that VHL is by far clearly the leading cause here, and we have to consider VHL in a very important perspective from a pediatric perspective. You already laid down specific guidelines with regards to follow-up. And I think this has been a wonderful presentation. We've been discussing about right from diagnostic criteria to evaluation and management from that perspective. What is your take in terms of long-term outcome that we have seen in these cases in terms of their overall morbidity, mortality, and other factors across life, Dr. Vijay?
So usually these patients do have a metastasis, do relatively well, though I don't assure that they're going to have a very good outcome like 20, 30 years. But usually, even the metastatic PPGL do have a relatively good survival at 5 years and 10 years. And especially with evolving modalities like now we are giving iodine 131 MIBG and even the PRRT, even though we don't have particular experience, even the actinium-based PRRT is coming up, which is giving a relatively good efficacy even for PPGL. And so probably with this, at least like our metastatic patients also have a median survival of around 8 to 10 years now. So that's a good thing which we are able to attain, but the long-term outcome by when they are maybe their 30s or 40s, probably we lose all of them. So that's the usual outcome for a metastatic PPGL. Whereas the benign PPGL, they will have a very good outcome. So that's not all a problem. Even if they recur, we are able to cure them again. That's not a main problem. But as I told earlier, a set of VHL patients, they do die of the aggressive PNETs, whereas a set of our MEN2A and MEN2B patients are dying because of metastatic MTC, especially if they have not been identified and undergone prophylactic thyroidectomy in the early stage. Whereas for the SDHB, it is typically the PPGL which is the killer. Whereas for the VHL and the MEN2A, MEN2B, it is the associated tumors which are really the killers.
So I think that's a very, very important point that we have to really keep our eyes and ears open with regards to the other associations. And as you said, MDC, of course, is very, very important from that perspective. And in your experience, do you see any difference in outcome if you're able to pick it up early? Like if you have somebody who has a metastatic potential and you pick it up early versus a bit later, how much difference does that make?
Definitely difficult to comment on this, sir, because we really did not have so much of data to analyze, the synchronous metastasis versus metachronous metastasis and early diagnosis. Probably we won't be able to give this. But logically, definitely, it's worth picking up a metastatic disease at the earliest, so that like we institute a therapy which could probably be more beneficial. So probably that could be the comment.
That's a very important point. And of course, if you're able to pick it up, we are in a way preventing it at an early stage. So I think that's a very wonderful talk which is coming out from there. So if there are any questions there, we can take them up, or probably we are coming close to the termination of the session. Is there any questions, Dr. Jhalak?
I have a
No,
question.
I don't find any questions
Yeah,
here.
Dr. Ahila, please go ahead. Dr. Vijay, you can switch off you can stop the slide sharing so that you can see your face.
Sure.
If you incidentally get a MEN2 mutation in a child, when would you advise a prophylactic thyroidectomy?
If it's already PCC simultaneously diagnosed, so obviously I would go for the PCC.
It's
No,
not
incidental diagnosis.
just an incidentally diagnosed MEN2 mutation.
MEN2A. So it's again based on the what type of mutation we have. If it is a like moderate risk or a low risk or a high risk. So if it's obviously high risk, is typically MEN2B or a 634 mutation, which is typically high risk. So in them, maybe by 1 year of age only, we should ask them to undergo prophylactic thyroidectomy. Whereas the moderate risk, maybe by 5 years. So whereas the mutations which have a low risk, probably we can keep them under surveillance if somebody is not really willing to undergo prophylactic thyroidectomy with a close monitoring of serum calcitonin and the ultrasound neck. But usually by 10 years, we push them to undergo prophylactic thyroidectomy.
And the earlier that you've seen MEN2 with Pheo?
We have a 16-year-old child who had both RET and this one, but somehow in the SGPJ cohort, so I have went through that cohort when I was doing a meta-analysis, but they have a higher proportion of RET tumors. So probably that may apply to UP as well, I don't know. But this is the typical report from SGPJ cohort where they have a larger proportion of, and even relatively younger MEN2 patients who have come up with the field.
Yeah, so generally we don't expect in the before second decade. It's usually beyond that. But by that time, the thyroid carcinoma would already have created a havoc in most cases. So if it's an aggressive form. So are there any questions, Dr. Jhalak?
No, sir, I don't find any in the chat box.
So I think I'll hand it over to you for concluding remarks there. And it was a wonderful session. Once again, thanks Dr. Vijay and Dr. Harish for this wonderful presentation, and Dr. Ahila and Dr. Jhalak for really conducting this session in a remarkable fashion. Thank you.
Thank you, sir.
Thank you so much, Anurag and Vijay Sarthi, for that wonderful session, and Dr. Harish for that absolutely brilliant presentation.
Thank you. Thank you, sir.
Yeah, thank you, sir. And I will leave it to Zalak to thank everyone. Before that, I would also like to thank Zalak. She's done a fantastic job, and kudos to you, and you've done brilliantly. All the best. And she will give the word of thanks.
I would like to thank Dr. Christina. She left. She had another meeting to attend. Dr. Vandana Jain, Dr. Meghna, Dr. Anurag Bajpai, Dr. Harish, and Dr. Vijay Sarthi. We understand it takes a lot of effort and time to make this possible. We deeply appreciate it. I would also like to thank Dr. Ahila for being the chairperson tonight. I thank all the attendees today. We come up with the next meeting on 24th of June after 3 months. See you all soon. Good night.
Good night.
Thank you very much. And thanks, Shaila, for starting this wonderful ISPAE session. Thank you very much. Bye.
Thank you all.
Bye.
Pleasure. Good night.